Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 175 of our Pharmacotherapy MCQ series, which majors in infectious diseases. As the clinical pharmacist in the infectious diseases team at your hospital, you receive a draft of the Institutional Guideline for the Management of Acute Bacterial Rhinosinusitis, abbreviated as ABRS, for review. The working group seeks specific recommendations for appropriate adjunctive therapies for patients diagnosed with or suspected to suffer from ABRS. Which of the following is the best evidence-based recommendation for all patients presenting with ABRS based on the 2012 IDSA Clinical Practice Guideline for ABRS in children and adults? Is it A. intranasal corticosteroids, or B. intranasal decongestants, or C. intranasal saline irrigation, or is it D. intranasal tobramycin irrigation? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. intranasal saline irrigation. There is no recommendation to support the use of intranasal antibiotic solution irrigations as adjunctive therapy for patients with ABRS in the 2012 Infectious Diseases Society of America Clinical Practice Guideline for Acute Bacterial Rhinosinusitis in Children and Adults. Intranasal saline irrigation is recommended in the 2012 Infectious Diseases Society of America Clinical Practice Guideline as an adjunctive therapy for adults with ABRS. Although the recommendation is weak with low to moderate evidence, it can be applied to all patients with ABRS. Intranasal and other topical preparations of decongestants are not recommended as adjunctive therapies for the management of ABRS based on a strong recommendation with a low to moderate level of evidence in the 2012 Infectious Diseases Society of America Clinical Practice Guideline for Acute Bacterial Rhinosinusitis in Children and Adults. Intranasal corticosteroids are recommended as an adjunctive therapy in the 2012 Infectious Diseases Society of America Clinical Practice Guideline for Acute Bacterial Rhinosinusitis. However, the evidence is from patients with a history of allergic rhinitis, which is a limitation in applying use of this therapy to all patients with ABRS for the institutional guideline. Please advance to the next question. And the next question reads, BMK, a 55-year-old male patient presents to your accident and emergency department with a chief complaint of nasal congestion, mucopurulent drainage, and anosmia. He reports that these symptoms have been present for more than 90 days and he has been self-treating them with over-the-counter intranasal fluticasone spray with some relief. He has a past medical history significant for asthma, prostate cancer. He is now in remission. Radiographic imaging shows inflammation in the sinus cavities. BMK took a 10-day course of antibiotics at some point in the last 28 days but cannot recall which one he received, although he is confident that he completed the therapy. So my question to you is, which of the following interventions would be the most appropriate for BMK now? Would it be A. Provide the patient with supportive care and recommend irrigation with intranasal saline, or B. Initiate therapy with azithromycin 250 mg by orally once daily for 5 days, or C. Provide the patient with supportive care and systemic corticosteroids for 10 days, or would it be D. Initiate therapy with doxycycline 100 mg orally twice daily for 10 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Provide the patient with supportive care and recommend irrigation with intranasal saline. This patient displays features of chronic rhinosinusitis based on the duration of symptoms exceeding 12 weeks, presence of nasal congestion, and evidence of inflammation. Although chronic sinusitis can be characterized by acute exacerbations, in most cases it is a chronic inflammatory process with different microbiology associated with biofilm formation in the nasal passages. Use of antibiotics in the management of chronic rhinosinusitis is not advocated because it can alter the flora and increase the risk of an acute exacerbation for which a short course of antibiotics may be warranted. There are limited data suggesting that use of macrolide antibiotics or doxycycline may improve symptoms in patients with chronic rhinosinusitis, but this improvement is thought to be due to the anti-inflammatory modulation that these antibacterial agents provide in what is primarily an inflammatory process. Therefore, starting doxycycline is not the best choice for this patient. Providing the patient with supportive care and recommending irrigation with intranasal saline is a better choice for this patient and is the most appropriate intervention for this patient. Currently there is no consensus about the use of systemic corticosteroids for chronic rhinosinusitis, and the risk-benefit profile of using these agents for the management of this condition does not support recommending routine use. Please proceed to the next question. And the next question reads, OJW, a 57-year-old male patient presents to your accident and emergency department in December with a chief complaint of COPD exacerbation and forced expiratory volume in 1 second, abbreviated as FEV1 of 55% of the predicted value. He has had 2 prior COPD exacerbations leading to hospitalization since his diagnosis. His COPD assessment test, abbreviated as CAT score, is 12. He has a past medical history significant for coronary artery disease and COPD. Regarding his social history, he recently quit smoking after a 10-pack year. His pertinent vitals include a respiratory rate of 35 breaths per minute, and his oxygen saturation has improved with the administration of supplemental oxygen. The chest physician on call would like a recommendation for ongoing follow-up to include pharmacotherapy options to prevent acute exacerbations of COPD. So my question to you is, which of the following would be the most appropriate evidence-based recommendation for OJW now? Would it be A. Initiate moxifloxacin 400 mg orally once daily for 5 days, or B. Initiate prednisone 40 mg orally once daily, or C. Administer the annual influenza vaccine and the 23-valent pneumococcal polysaccharide vaccine, abbreviated as PPSV23, once the patient's condition is stable, or, would it be, D. Administer the 13-valent pneumococcal conjugate vaccine, abbreviated as PCV13, once the patient's condition is stable. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Administer the annual influenza vaccine and the 23-valent pneumococcal polysaccharide vaccine, abbreviated as PPSV23, once the patient's condition is stable. The PPSV23 vaccine should be given to patients 19 to 64 years of age with chronic lung disease because of their high risk for invasive pneumococcal disease. This 57-year-old patient should receive it now along with the annual influenza vaccine. Both the annual influenza vaccine and pneumococcal vaccines have been shown in multiple studies to decrease the frequency of COPD exacerbations. Once the patient turns 65, a dose of PCV13 should be given followed by a second dose of PPSV23 1 year after PCV13 and at least 5 years after the last PPSV23 dose. Systemic corticosteroids may be recommended for patients with an acute exacerbation of COPD. However, prolonged daily use of systemic corticosteroids is not associated with a decrease in the frequency of COPD exacerbations. Inhaled corticosteroids have been shown to reduce the frequency of acute exacerbations when given in conjunction with a long-acting beta-2 agonist, abbreviated as LABA, or as part of a 3-drug combination with a LABA and a long-acting muscarinic antagonist. The phosphodiesterase 4 inhibitor roflumilast is another anti-inflammatory therapy that can be considered for prophylaxis of acute exacerbations of COPD. Fluoroquinolones can be useful in the management of COPD exacerbations when there are signs of bacterial infection based on elevated C-reactive protein levels and white blood cell counts, even in the absence of culture data. However, this patient does not meet the criteria for use of antimicrobial therapy at this time based on his uncomplicated COPD exacerbation. The use of antibiotics for acute exacerbations does not decrease the frequency of future exacerbations, even in patients like OJW with heart disease. Please advance to the next question. And the next question reads, MDB, a 64-year-old female patient presents to your chest clinic with a past medical history significant for COPD grade 2, category B. She has been stable on therapy with an inhaled long-acting beta-2 agonist, abbreviated as LABA, and an inhaled corticosteroid, abbreviated as ICS, for the last half a year. Her other underlying conditions include chronic bronchitis, which she manages using multiple courses of systemic corticosteroids throughout the year, osteopenia and dyslipidemia, for which she takes vitamin D and calcium citrate and atorvastatin, respectively. So my question to you is, which of the following would most likely increase MDB's risk for upper and lower respiratory tract infections, including pneumonia? Would it be A. She does not have an increased risk for upper or lower respiratory tract infections based on her comorbidities, or B. Exposure to systemic and inhaled corticosteroids, or C. Dyslipidemia, or would it be D. Advanced age? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Exposure to systemic and inhaled corticosteroids. Age greater than 65 years is associated with higher mortality when hospitalized for pneumonia or sepsis. However, this patient is only 64. Dyslipidemia and other comorbidities can increase the risk of hospitalization when pneumonia is present. However, this association is weak compared with the ongoing debate relative to exposure of patients with COPD to systemic corticosteroids and their risk of infection through downregulation of key inflammatory modulators that play a role in natural defense mechanisms that protect against infection. This patient is at risk for pneumonia because of her COPD and exposure to multiple courses of systemic corticosteroids that suppress her immune system. Although short courses of corticosteroids may improve outcomes in patients with COPD or bronchitis, multiple courses of systemic corticosteroids can predispose patients with COPD and bronchitis to pneumonia. This increased risk is a heavily debated phenomenon that is multifactorial in its pathogenesis. Although Cochrane review data suggest that this association may not be as strong as previously was thought, the 2017 Global Initiative for Chronic Obstructive Lung Disease Guidelines, abbreviated as GOLD guidelines, encourage limited use and short courses of systemic corticosteroids when needed for acute COPD exacerbations. In the UPLIFT trial, an increased risk for pneumonia and respiratory adverse events were associated with exposure to corticosteroids even by the inhaled route in patients with COPD. This patient's exposure to systemic and inhaled corticosteroids increase her risk for pneumonia and other upper and lower respiratory infections. Please proceed to the next question. And the next question reads, LSK, a 57-year-old female patient presents to the chest clinic for a wellness checkup following a recent visit for an upper respiratory infection with accompanying fever. She has a past medical history significant for non-ST segment myocardial infarction, seasonal allergic rhinitis, type 2 diabetes mellitus, and COPD. You establish that she has not yet received any pneumococcal vaccination. So my question to you is, which of the following would be a contraindication to immunization with the 13-valent pneumococcal conjugate vaccine, abbreviated as PCV13, in LSK's case today? Would it be A. anaphylaxis to latex and latex-containing products, or B. anaphylaxis to the hepatitis B vaccine, or C. anaphylaxis to the diphtheria tetanus vaccine, or would it be D. recent upper respiratory infection with accompanying fever? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. anaphylaxis to the diphtheria tetanus vaccine. The only contraindication to PCV13 is severe allergic reaction, e.g., anaphylaxis, to any component of the PCV13 vaccine or any diphtheria toxoid-containing vaccine. Precautions in the use of PCV13 apply only to patients with moderate illness, including fever, which means that this patient could receive PCV13 despite her recent illness and fever, with monitoring in the office. Please progress to the next question. And the next question reads, KAA, a 55-year-old female patient presents to your accident and emergency department shortly before admission to your medical intensive care unit for management of hyperglycemic hyperosmolar state. She has a past medical history significant for type 2 diabetes mellitus, chronic kidney disease, and COPD. On hospital day 4, she develops signs and symptoms consistent with pneumonia. KAA subsequently requires intubation due to severe hypoxia and vasopressor support for suspected septic shock. KAA was hospitalized 2 months ago for a diabetic foot infection requiring intravenous IV antibiotic therapy. So my question to you is, which of the regimens listed below would be the most appropriate empiric antibiotic therapy for KAA's suspected pneumonia? Would it be A. vancomycin plus cefepime plus moxifloxacin, or B. linezolid plus piperacillin, tazobactam plus ciprofloxacin, or C. vancomycin plus cefepime, or would it be D. linezolid plus ertapenem plus tobramycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. linezolid plus piperacillin, tazobactam plus ciprofloxacin. Linezolid plus piperacillin tazobactam plus ciprofloxacin is the best choice for KAA because it provides coverage for methicillin-resistant Staphylococcus aureus (MRSA) and double coverage for Pseudomonas aeruginosa. These agents are indicated because KAA's pneumonia is hospital-acquired, she has a high mortality risk, a need for ventilator support and suspected septic shock, and she received IV antibiotic therapy within the past 90 days, i.e., she is at risk for MRSA and multidrug-resistant Pseudomonas aeruginosa. Linezolid plus ertapenem plus tobramycin is not a good choice for KAA because ertapenem does not provide coverage for Pseudomonas aeruginosa, leaving the patient with only single drug coverage, i.e., tobramycin, despite an indication for double coverage. Vancomycin plus cefepime is not appropriate because it provides only single drug coverage, i.e., cefepime, for Pseudomonas aeruginosa despite an indication for double coverage. Vancomycin plus cefepime plus moxifloxacin is not appropriate because moxifloxacin does not provide coverage for Pseudomonas aeruginosa, leaving the patient with only single drug coverage, i.e., cefepime, despite an indication for double coverage. Please proceed to the next question. And the next question reads, JCC, a 29-year-old female patient was admitted to the trauma ICU after a motor vehicle crash. She subsequently developed ventilator-associated pneumonia. She has no significant past medical history. Her culture results include Pseudomonas aeruginosa that is susceptible to piperacillin, tazobactam. With an MIC of 16/4 mg per liter, resistant to cefepime and ceftazidime. Her current meds include piperacillin, tazobactam 3.375 grams infused intravenously over 30 minutes thrice daily. Her pertinent labs include a creatinine clearance of 120 ml per minute. So my question to you is, which of the following alternative piperacillin, tazobactam dosing regimens should be avoided in JCC because attainment of pharmacokinetic and pharmacodynamics targets is least likely? Is it A. 10.125 grams every 24 hours as a continuous IV infusion, or B. 4.5 grams IV infused over 30 minutes thrice daily, or C. 4.5 grams IV infused over 30 minutes 4 times daily, or is it D. 3.375 grams IV infused over 3 hours thrice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. 4.5 grams IV infused over 30 minutes thrice daily. Use of piperacillin tazobactam 3.375 grams IV infused over 3 hours every 8 hours, i.e., an extended infusion, has been shown to substantially increase the time above the minimum inhibitory concentration for beta-lactam antibiotics, including piperacillin tazobactam. Therefore, this dosing strategy need not be avoided in JCC. Use of piperacillin tazobactam 4.5 grams IV infused over 30 minutes every 6 hours, i.e., shortening the dosing interval, has been shown to substantially increase the time above the minimum inhibitory concentration for beta-lactam antibiotics, including piperacillin tazobactam. Therefore, this dosing strategy need not be avoided in JCC. Use of piperacillin tazobactam 4.5 grams IV infused over 30 minutes every 8 hours, i.e., increasing the dose, has been shown to result in marginal increases in the time above the minimum inhibitory concentration (MIC) for beta-lactam antibiotics with short half-lives, such as piperacillin tazobactam, in patients like JCC with normal renal function. Therefore, this dosing strategy would be least likely to achieve an optimal time above the MIC and should be avoided for this patient. Use of piperacillin tazobactam 10.125 grams every 24 hours as a continuous IV infusion need not be avoided in JCC because continuous IV infusions have been shown to substantially increase the time above the minimum inhibitory concentration for beta-lactam antibiotics, including piperacillin tazobactam. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 176.